Hi guys, it's me, Professor D, and welcome back to my YouTube channel. Merry belated Christmas. I don't know what you guys have been doing this holiday break, but let me tell you what I've been doing. I've been watching Matlock. I've been watching Murder, She Wrote. I've been watching ER. And what else have I been watching? Those three. And I'm living my best life. So I hope you're also enjoying your Christmas break. So anyway, this video, we're going to be doing another Kahoot and we're going to be going over fractures. This is going to be a very short Kahoot. I think it's only about 10 slides, but I'm going over just important content that you do need to know about fractures. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. So go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX reviews. You can reserve your spot for a session, both part 1 and part 2, by going to my website, nexusnursinginstitute.com. If you're currently in the nursing program and you just need that extra push, you have a quiz or an exam coming up and you have to do really, really well, be sure to check out the subjects I have on my audio lessons. Those can also be found on my website, nexusnursinginstitute.com. All right, guys, without any further ado, let's get started. Fractures. Okay, your patient is in traction. Which action will help prevent muscle atrophy? Is it adducting the affected leg, flexing the affected leg, performing isometric exercises to the affected leg, or adding weight to the traction? Your patient is in traction. What's going to help prevent muscle atrophy? What do you guys think? Very good. Performing isometric exercises to the affected leg. So when you look at this question where I'm asking you about what's going to prevent muscle atrophy, what is muscle atrophy? That's that bone. That's the muscle getting weak and shrinking, right? We want to prevent that from happening. We want the muscle to be strong. So something that will help is performing isometric exercises. And here's why. When you're doing isometric exercises, you're causing tension to the actual muscle, but you're not moving that leg. You're causing tension to the muscle. You're making that muscle get stronger without there being movement. Okay. Adduction of the leg, flexing the leg, and adding weight. You know, you never add weight to traction. Okay. That weight on the traction, that's actually a prescription. But anyway, those other choices, that's not going to do anything to actually strengthen the muscle of the leg to prevent atrophy, but isometric exercises does, increases the tension, makes the muscle stronger without actually causing movement, because you know when the affected leg that's in traction should not be moving. Okay, your patient with a fracture is taking methylcarbamol. Which finding indicates a desired outcome? Is it the absence of infection, decreased itching, decreased muscle spasms, or decreased nervousness? What do you think the answer is? Your patient with a fracture is taking methylcarbamol. Which finding indicates a desired outcome? Very good. Decreased muscle spasm, because this is a muscle relaxer. By the way, I say this all the time on the Kahoot, I don't have enough characters, so I can't type the questions as you would see them appear on NCLEX. They're not going to look like the NCLEX questions just because I don't have enough characters. So what I do on the Kahoot is I give you the foundation, I give you the basis of the question. So on NCLEX, you may get a whole case study, but the point of that case study is to ask you this. And so those are the questions I give you, but I don't want you to think by any means these are the type of questions you're going to see on NCLEX. They're not. These are the points that you're going to see on NCLEX that NCLEX expects you to get to, okay? So anyway, what I want to say to you guys about this line, what do I want to say? Okay, I know what I want to say. So when it comes to NCLEX, something important you guys got to know, when it comes to medications, you have to be cautious. You have to be aware of what you're being asked. When it comes to medications, 99% of the time, you're either being asked about an adverse effect, something that may possibly happen, that absolutely no circumstances do we want it to happen. So we tell them, if this happens, report it right away, because we expect their dosage or their medication to be changed, right? That's the adverse effect. You may be asked about a side effect, something that may possibly happen. We don't want it to happen, but we're going to warn them, hey, this may happen, so they don't stop taking their medication. Indication. Indication is why you're giving this med. Now, with this new next generation NCLEX, I see them asking less of that type of question, the drug indication, because that's easy. You know it or you don't. Why are you giving this drug? I'm seeing it less. They're still asking about drug indications, but not as often. But you still need to know why this medication is given. There's a fourth one, your nursing interventions for that medication. Here's where students go wrong. You will get a diagnosis and you'll get a medication that you're either about to give or you just gave. And you will sit there and focus on the patient's diagnosis. Why are you doing that? It's not that we don't care about the diagnosis, but the reason we're giving the medication is because of the diagnosis. So forget that diagnosis. When you see the medication is what you need to be focusing on. That chemical that we're either about to put into that patient's body or that we just put into that patient's body, that's what we care about. So be very careful when you're looking at your answer choices and make sure you're answering to the medication and not the patient's diagnosis, because that's where a lot of students go wrong, okay? Moving on. All right, so a geriatric patient is admitted with a femur fracture. What would you assess first? Would it be the ability for them to move the affected extremity? Would it be the type of pain that they're experiencing? Would it be the mechanism of injury? Or would it be the extent of anxiety? You have a geriatric patient that is admitted with a fracture of the femur. Which should you assess first? It is not pain type. It I'm gonna talk to you guys about the pain type in a second. It is not pain type. It's the mechanism of injury. Why? How they fractured that femur is going to give you an idea of the type of diagnostic tests that you expect to be ordered, about associated injuries that that patient may have that you need to be assessing for. Okay, so the priority assessment is going to be the mechanism. How did they get that fracture? And that's going to give you an idea of other things that you should be assessing for. Not saying that, the pain type is not important. It is. But if you have to choose one thing, it's going to be how they injured it. And guess what? Knowing how they injured it, that's going to give you an idea to the pain type. You're still going to ask about it, but that's not going to be your priority. Look at the other choices. First of all, ability to move the affected extremity. What do we know about fractures? Rice, rest, ice, compression, elevation. Rest. We want to rest. We want to immobilize that extremity. We're not going to be trying to make them move it. So that's wrong. Now, let me talk to you about pain type. When you're asked about something you're going to do first, something that's a priority, let me tell you when pain is the priority. Burns, sickle cell, burns, sickle cell. I'm having a brain fart. What's my third one? Stones, like kidney stones, gallbladder stones, cancer, and myocardial infarction, those 5. Okay. When the patient has one of those diagnoses, pain is going to be a priority. And last, extent of anxiety. Guys, physiological integrity, Maslow's hierarchy of needs. Anxiety is all the way up here. You have to make sure that you're keeping the patient alive, right? You have to address the patient's physiological integrity first before you care about their anxiety, before you care about emotions, before you even care about teaching. Okay, so the correct answer for this is mechanism of injury. One more thing I want to bring to your attention, and NCLEX is big on this. They expect you to know this. When you're dealing with geriatric patients, the rule of the game, go slow. Start low, go slow. Why? It's wear and tear of the body. Okay, the kidney's not working the way it used to, so they're not going to be excreting these medications the way that they used to, so they're going to be at high risk for toxic levels of medications. Their liver's not working the way it used to. That means they're not metabolizing these drugs the way that they used to. That means that they're at risk for what? Drug toxicity. So that's very important when it comes to the geriatric patient as well. All right, after a long leg cast has been removed, the patient should be instructed, look at that long leg cast, elevate the leg when sitting, report any stiffness of the leg, perform full range of motion exercises daily, cleanse the area by scrubbing with a soapy cloth. Again, after a long leg cast has been removed, what should the patient be instructed to do? The reason I told you guys to take a look at this long leg cast, I've got a lot of feedback from my students who've taken NCLEX. They've gotten an easy question like this where they'll ask for a specific type of cast, and you just have to, you'll see different illustrations and you have to move your mouse to the correct type of cast. So make sure you know your different types of casts, okay? But anyway, the correct answer is elevate the leg when. How did 31 of you say perform full range of motion? Let's think about this for a second. This patient has a cast, right? Which means they have a what? They got a fracture. How's that patient going to do full range of motion? Are you serious? Come on. No, you're going to elevate the leg when sitting. When that patient is in a dependent position, you're going to want to elevate that affected extremity. And the reason why, remember the cast, it does not expand. It doesn't move. So imagine that patient sitting down in a dependent position and all of the fluid, all the electrolytes, all the blood, it all pulls down to the bottom where their feet is, right? Because of gravity. So now you have swelling in an area that shouldn't be swelling because remember, the cast doesn't swell. You got pressure. You're putting that patient at risk for what? Compartment syndrome. And that's what we want to avoid. So you're going to teach them to elevate that leg when sitting. Come on, guys. We got to do better. How are you guys doing on the live? I'm sorry, I didn't mean to yell at you. You know I love you guys. All right. Your patient with an arm fracture is in skeletal traction. What is the purpose of traction? Is it to protect the skin integrity? Does it prevent movement of the extremity? Does it preserve the length of the extremity, or does it reduce and immobilize the fracture? Your patient with an arm fracture is in skeletal traction. What is the purpose of traction? Very good. It reduces and immobilizes the extremity. Make sure this is another thing. NCLEX definitely wants you to know the difference between skin traction, skeletal traction. So make sure you know the difference between those two. Make sure you know the types. Make sure you understand that skin traction is short term, where skeletal traction is longer term. With skeletal traction, the patient's more at risk for infection. With skin traction, a big concern is going to be integrity of the skin, okay? Make sure you guys review that. Which statement requires further teaching about cast care? If the patient says which statement, I will elevate the cast above the level of the heart. I will exercise the joints above and below the fracture. I will use a padded ruler to scratch inside the cast. I will keep the cast dry. Which statement requires further teaching about cast care? Very good. I will use a padded ruler to scratch it inside of the cast. You don't stick anything inside of that cast, not a ruler, not a pen, not a hanger, not anything, because you can cause and a what's the word I'm looking for? Disrupt the continuity. No, I'm saying that incorrectly. Listen, let me just say how I know. So you don't want to cause a cut in the patient's skin because, guys, I'm sorry, I've been on Christmas break and my brain is not thinking nurse. I don't know where I am. But anyway, you don't want to cause a cut, because guess what? You cause a cut, that is a perfect opening for pathogens and bacteria to settle in, and boom, the patient's got an infection. You don't want to do that. So you teach them not to stick anything down the cast. Now the cast can be itchy, so what you teach them is if they have a blow dryer, put it on not hot, not warm, but cool. Put it on a cool setting and they could blow it like through the cast, and that can help with the itching, okay? So we don't want to decrease their skin integrity. So all of the other choices are correct. These are good things to do. That's why we didn't choose it as an answer. Whenever you see, and this is another thing, guys, make sure you're not reading too fast, because You may know the answer, but because you read too fast, you got it wrong. Whenever you see a question asking you about further teaching, which requires further teaching, which requires further follow-up, which requires clarification, all of those are nice ways of saying which one's a wrong answer choice. So that's what you'd be looking for. After surgery for a hip fracture, the patient complains of pain. What should be your first nursing action? Notify the healthcare provider, teach the patient relaxation techniques, administer analgesics as ordered, or perform a pain assessment. After surgery for a hip fracture, the patient complains of pain. What should be your first nursing action? That's right. Perform a pain assessment. You're going to be doing neural checks on this patient, and you're just going to be assessing this patient. AdPi, something's wrong. The first thing you're going to do is get more information, whether it be doing a physical examination of the patient, asking the patient a question, going through the chart to look up information. Anything you do to get information is considered a type of assessment. That's what you're going to do. Whenever something's wrong, you're going to do an assessment, get information. Now, there's something else I wanted to say to you. What else did I want to say to you after surgery? Oh, here's the second thing I want to say. Remember, guys, after patients had surgery, doesn't matter what type of surgery the patient had, if they had an invasive procedure, your top three concerns, the three things you're going to be watching out for, you're going to be assessing, you're going to be worried about, you're going to be concerned, are going to be infection, right? So you're going to be, looking at the WBCs, you're going to be checking the patient's temperature, you're going to be looking at that surgical site, make sure that it's not red or inflamed, make sure there's no mucopurulent drainage, there's no foul odor, stuff like that. There's no redness. Infection. Your infection, we're more likely to see that after that first 12 hours. That's where it's more likely, but it can still happen within the first 12 hours. The second thing we're going to be concerned about is going to be hemorrhage. You're going to be concerned about your patient bleeding internally. So you're going to be watching out for that. You're going to be watching out for, decreased blood pressure, decreased RBC, decreased H&H, increased heart rate, increased respirations, decreased urine output, all those signs and symptoms that patient's possibly bleeding out. Even looking at their skin color, right? Are they turning pale? Are they turning blue? That. And the third thing you're going to be concerned about is that patient developing a DVT, them having that unilateral foot pain or calf pain, or that DVT, that clot dislodging and going to the pulmonary artery. And now this patient's got a pulmonary embolism. You're going to be watching out for cough, shortness of breath, difficulty, breathing. You're going to be looking at the SaO2. By the way, we want the SaO2 95% or higher. If it's 91 or lower, that patient's in respiratory distress. So you're going to be watching out for those three things: infection, hemorrhage, and DVT or pulmonary embolism. Whenever you see the patient's had an invasive surgery, always think about those three. Your patient has developed compartment syndrome. Ooh. Which symptom would alert you to impending organ failure? Would it be crackles, jaundice, generalized edema, or oliguria? Your patient's developed compartment syndrome. Which symptom would alert you to impending organ failure? Oh, you guys are so wrong on the live. I hope you guys are doing better on the Kahoot. It's oliguria. Wow. Most of you guys chose jaundice, which, I mean, okay. You guys chose jaundice. I'm assuming you're thinking about the liver, but let's talk about this. Your patient has compartment syndrome. By the way, you're doing all these neural checks on your patient that has a cast, that had a fracture, that's a traction. We're doing all of these neural checks. We are concerned about compartment syndrome. This is a medical emergency, right? If you see any of those symptoms, such as, pain, and when I say pain, I'm not talking about just normal pain, because obviously the patient had a fracture If the patient's in they're going to be in pain. I'm talking about pain that surpasses expectation, pain that surpasses what evidence-based practice has shown us the patient should be in. So if we're medicating that patient with an opioid narcotic and that pain is still increasing, that pain has surpassed our expectations, okay? You're going to be concerned about compartment syndrome, pain, paralysis, they can't move that area, poikothermesis, that area's cool instead of warm, paresthesia, where they have that pins and needles feeling, that's 4. Pallor, where instead of, the skin being nice and pink where you can see the circulation, it's pale, it's white, and I'm missing a 6. I always miss a 6th one. What's the 6th one of the compartment syndrome, guys? I never remember the 6th one. But anyway, there's 6 of them. You're going to do your neuro checks because we're concerned about compartment syndrome. Let me tell you something. If your patient ends up having compartment syndrome and an extremity has to be amputated, guess who's standing before the board of nursing? You are, because you should have caught it. You should have caught it. That shows bad nursing. And don't shoot the messenger. I'm just warning you, okay? Your patient has compartment syndrome. Immediately, do you know what the emergency surgery for that is? It's called a fasciotomy. But anyway, going back to this question, your patient has developed compartment syndrome. They've got it already. What symptoms going to let you know that the organs are shutting down? You should have been thinking about the kidneys and it's oliguria. So what happens is, as those muscle cells start to die, they release myoglobin, and that myoglobin, what happens, it gets stuck in the renal tubules. And when the kidney's in trouble, what's the first thing the kidneys do? Shut down. So you know how the patient's supposed to be releasing at least, at the minimum, 30 mLs per hour? Forget it. So as you see the urine output go down, this patient's in big trouble, okay? The correct answer is oliguria. All right, your patient has a femur fracture, which would be a symptom that the patient is developing a fat embolism. Would it be development of respiratory distress, seizures, blurred vision, or muscle spasms? Patient has a femur fracture, which will be a symptom that the patient may be developing a fat embolism. Absolutely, of course. Respiratory distress, cough, shortness of breath, dyspnea, all those signs and symptoms. By the way, if you get a case study or you get a question about a patient with a long bone fracture, such as the femur, those are one of your concerns because remember, those fat globules, where are they living? In the long bone. So if that long bone gets broken, those fat globules, what do you think they're floating in? The circulatory system, right? So that can cause a fat embolism. Your patient presents with a left radial fracture. What would you assess for first? Would it be the area proximal to the fracture? Would it be the area distal to the fracture? Would it be the actual fracture site? Or would it be opposite lower arm to compare and have a baseline? Your patient presents with a left radial fracture. Which would you assess first? Oh, you guys did great on the live this time. You guys know the answer to this one. Very good. Good. Area distal to the fracture. You always want to assess the area distal to the fracture. Why? Because you want to see, is there circulation, right? Again, guys, you're going to be doing your 6Ps, you're going to be doing your neuro checks, and you're going to be assessing the area distal to that fracture. Very good. Last question. Your patient's in a cast and they report increased pain despite administration of morphine. Which would you assess next? Would it be distal pulse, pain rating scale of 1 to 10? Would you check vital signs or would you check for symptoms of drug tolerance? Your patient in the cast is reporting increasing pain despite the fact that they just got morphine. What would you be assessing next? Very good, distal pulses. It's all about the neuro checks and preventing compartment syndrome. You see pain rating, a scale of 1 to 10, that is not going to help us in the situation because we already know that despite giving them morphine, they're still in pain, increased pain. So that's not going to help us in the situation. That's not going to tell us what we should do next. Taking their vital signs, that is not going to give us any idea if there is impending compartment syndrome, right? And of course, symptoms of drug tolerance, you're not going to suspect that all of a sudden your patient's a druggie. Absolutely not. You should be suspecting compartment syndrome. So you are going to be doing your neuro checks. You're going to be assessing all those P's. So the correct answer is distal pulses. All right, guys, you did a great job. Let's see who won this Kahoot.